This is an area that I think is fraught with a lot of controversy because I was recently awarded one of the two early therapeutic sequencing hubs, I brought a team together at Yale, and we were one of two. The other one was Harvard. And so why this I think is so relevant to that issue is we have established a 409 gene panel, and Harvard has an onco panel. And so when we started looking at it relative to early therapeutic drug development and tried to compare the two panels for validation, et cetera, to be able to use these panels interchangeably in terms of drug development of some of the novel drugs coming through the CTEP pipeline, we realized, wow, I mean, just looking at DNA damage repair sequencing needs were so disparate between the two panels. And so all that is sequencing is not created equal. And also there are a lot of challenges that we have to face moving forward to be able to use these, what I consider limited gene panels. And therein lies probably why next generation sequencing, I think in the future, at least in drug development, is probably going to lead the pack, but it has its own set of issues, which we'll be talking about, especially regarding what we need to offer to our patients relative to the data that we are going to be harvesting or obtaining. So obviously in oncology, currently the primary reason I think for profiling tumors is to find, hopefully, potential signatures for therapeutic intent. It's extremely, I think, investigational in many arenas, except for select areas like limited panels for lung cancer. But even in those limited panels for lung cancer, I sometimes sit there and think if only we knew more about the profiling up front, we may have been able to understand the why or why not of the drug response or its eventual progression. And in early therapeutics, I think it's becoming more and more important now, even within the immunotherapeutic arena, because it will hopefully help us better understand, again, why or why not, and be able to help define earlier on whether or not a therapeutic drug that we're taking into the clinical investigation has meaning to why it is or isn't responding. So it's often done when a patient has advanced cancer and has typically failed standard options, but it's also being considered earlier as a replacement for limited signature assessment. So currently, patient reporting is a controversial topic. I think there are many issues that rest in the type of sequencing conducted. I'm a firm believer that if you're going to do sequencing of significant mutational numbers and next-gen sequencing, you need a normal control so that you can subtract out the germline from the somatic. But then that lends itself to a lot of other problems, which we're going to be talking about in the next few minutes. And then what do you do with that normal data or the germline data once you have it? Or do you even get it in a report? And what do you tell the patient if we're doing both? So like I said, there are currently multiple platforms used for sequencing. Not all platforms are created equal. Even if you're going under a select target of investigation, there, as I said before, just in the DNA damage repair arena, there were huge differences, and we not only are validating our profiling capabilities, but we're also considering whether or not we have to go into next-gen sequencing in order to give us meaningful data at the end. And so next-gen sequencing, for obvious reasons, is becoming very popular. But like I said, the degree to which the normal is interrogated is currently a source of controversy. So regarding genomic sequencing, obviously, after you get all this data, you're going to have two buckets of information. If you've done your normal matched tumor pairs, you're going to get your somatic mutations, hopefully, that you can act on, hopefully, in the future, relevant to what is going on within the tumor. But you also get this other bucket that I'm going to be spending some time on, which are the incidental findings. And as a medical oncologist, I can honestly tell you that I don't feel comfortable discussing incidental findings with my patients, especially given all the underlying problems that they already have when they're coming into me. My patients all have advanced metastatic disease. So with that in mind, we all know, I think, what an incidental finding is, but it's a result that's not related to the indication for ordering the sequencing, but maybe of medical value or utility to the ordering physician or the patient or the patient's family. and the results of a deliberate search for pathogenic or likely pathogenic alterations in genes that are not apparently relevant to the diagnostic indication for which the sequencing test was ordered. So when you're focusing in one arena and suddenly you have this other bucket of data that you have to deal with, it becomes an enigma sometimes, and we have to be proactive and think about this now rather than later, because I think we're going to have to reestablish the teams for which we put in place from the FTE perspective as we're beginning to bring these patients in, interrogating them, their tumors and their normal genome, and moving forward with that data. So the ACMG, the American College of Molecular Genomics and Genetics, put out recommendations for reporting of the incidental findings in clinical exome and genome sequencing. And I often wondered, what were these all about? And unfortunately, when they put these out around 2013, they failed to incorporate in their working group, I think, some of the most pivotal people that could help them make their recommendations. They had no oncology people within the working group. They had no medical oncologists. They had no surgical oncologists. They essentially left out what I consider one of the most important personnel and component of the working group, because we are faced with these problems on a daily basis for which they made recommendations which are quite challenging. So just to go over briefly what the recommendations were, and there are subsets to each of these recommendations, but essentially they felt that constitutional foundation mutations that were found in genes on a minimum list, and the list was initially 57 genes and then subsequently was reiterated to 56. ACMG recommends that they be reported by the lab to the ordering clinician, regardless of the indication for which the sequencing was ordered. So then what do you do with that data? And in the future, what is going to be the medical liability once you obtain that data if you don't act on it accordingly? And I think that is another area and another, Pandora's box that will be opened in the future potentially. They felt that labs should seek and report only the type of variants within the genes that they had delineated, which were 56 non-cancer, or 56 genes and or variants not related to a cancer diagnosis, but some Mendelian. The ordering clinician team is responsible to provide comprehensive pre- and post-test counseling to the patient, which is challenging, but they don't tell you exactly how to do it. These recommendations, they felt, reflect the limitations of current technology and are therefore focused on disorders that are caused by point mutations and small indels, not those primarily caused by structural variants, repeat expansions, or copy number variations. And finally, their fifth major recommendation was that the working group recommended, together with content experts exclusive of what I think the most pivotal people would be, which were the oncology community and other professional organizations. And again, they excluded many of the most important professional organizations in the oncology arena. They felt that they should refine and update this list at least annually. And hopefully with subsequent updates, they will include those pivotal organizations and people. They then were getting a lot of flack from obviously the oncology community and the sequencing community, and we'll be talking a little bit about what I consider a white paper that was put out by Parsons and Samik Rao-Chaudhry from Ohio State and Arul Shanayan from University of Michigan. But they did put out a recommendation just April of this year that among the members of the ACMG, that patients should have the opportunity to opt out of the analysis of medically actionable genes when undergoing whole exome or genome sequencing. A lot of people felt that it was pretty controversial, that many patients would not want this anyway. But I can honestly tell you that even though we do normal and tumor paired, we really don't include in our consent forms, to the extent that we would need to, the issue of incidental findings. And we'll be talking about consenting in the next several minutes. This update to our recommendations moved the opt-out discussion to the point where the sample is sent rather than at the time when results are received by the ordering clinician, as was originally recommended. So even partnering it off or sending it out would be, a separate entity, which lends itself then to more follow-up, more record keeping and more FTE labor on the part of the ordering person that was harvesting the tissue in the blood or the normal variant. So, and they also recommended that because the field is moving so quickly that these had to be updated at least annually, that their recommendations should be updated at least annually. So how relevant is incidental findings in our patients to begin with? And I think this is a really good study that was published at the end of last year where they actually looked at 1,000 patients who had their exomes done and had normal paired. And basically what they found in this 1,000-patient study was that the actual incidence of incidental findings is 2.3%. And you say, well, 2.3%, that's really not that much. But with some of the less hypermutated tumors, just having that percentage within the tumor would be, something that we would look for. So 2.3% is not insignificant. And when you think about the only thing that we do is oncology, and we see a lot of patients with advanced disease, or even if these panels start going into the earlier stage, I think it's going to lend somewhat of a paradigm shift to how we can practice oncology in our practice and what knowledge base we will need to know as medical oncologists or clinicians that have to deliver this data. And also, how do we need to move forward in educating our patients so that they understand the relevance of an incidental finding to move forward and act on, even if they do want it. So this was, part of the paper that Samik and Arul put out with Dr. Parsons, where they said that, incidental finding recommendations were actually an incidental casualty. And there were a few other papers also written, as well as some currently being submitted or in press. But for the profiling community that deals primarily with oncology and is looking specifically at tumor profiling to help us make therapeutic decision making, this incidental casualty is a real problem that is possibly going to hurt us more than help us until we get a little farther ahead with where we're going. So as I said, there was no panel expert included in the working group. There were no surgical medical oncologists that were at all experienced in tumor genomic testing or from any cancer professional societies, in contrast to all the other working groups that the ACMG had in the past. And the recommendations they felt to routinely report when performing tumor and matched normal gene sequencing, especially considering these tumor tests to be equivalent to germline tests, raises several key questions. First of all, most of these guys that are profiling already have significant challenges, both technical as well as interpretive. Not only do they have challenges just within the data set that they're getting, because these are huge data sets, and they have to find appropriate bioinformaticians that are experienced in dealing with it, but then we also have to deal with all the issues within the tumor itself, such as tumor heterogeneity and clonal evolution. So when you're dealing with that massive amount of data, and some of us are still struggling with how best to access it, to evaluate it, and to report it out, adding incidental findings is another major hurdle. And the generation of the somatic mutation list and clinical report typically involves no specific analysis or annotation of germline variants. The labs currently do not have germline capabilities to produce the tumor-focused clinical reports. Going into germline variants is going to take an entire new set. You have to validate what you're doing. It's going to be a more costly run than the normal variants that we currently are looking for when we're doing tumor normal matched controls. And also, you have to report it out differently. And it's going to take extra time because of the amount of work that's involved. And most of the time, these patients are already waiting a few weeks to get these reports, especially if we're looking at them as predictive biomarkers, where we're trying to make real-time treatment decisions. It becomes problematic for the patients unless we then go back and have the ACMG or others redefine how we are going to report out the germlines relative to the normal, relative to the somatic mutations. And, they are analogous setups, but distinct setups. So it's going to be possibly, at least initially, quite prohibitive in cost if we're going to recommend this outside of an investigational arena. Because as somebody pointed out yesterday, a typical next-gen sequencing run was billed at about $5,800, and then you add a germline variant to that, and the cost becomes extremely prohibitive and astronomical. And it's not really the real reason why we're doing this to begin with. They can be extremely challenging because of the number of genes on the ACMG recommendation list. And, you know, it requires a different level of expertise, not only for the practicing physician, but also for the lab that's currently running it. And then you do have to follow through if you provide the results. You have to have the capacity to follow through as well as the resources needed. So you either have to refer that patient out to another institution or another investigator within your own institution, or you have to start developing a team approach to treating these cancer patients. So as I said before, we already are challenged with the reporting delay of tumor somatic mutations. On the GEM trial that we've been involved in, we were able to get whole genome, whole exome, and RNA sequencing compiled and reported out within 12 days. But I can tell you that that doesn't happen at my new institution, and that doesn't happen at the majority of institutions around the world. As I said, the cost is twofold, and if we're waiting for all this data, especially in the advanced setting, and we can't read out and we can't act on until we get both readouts, the patient could obviously die before we get the results, which can sometimes happen still at several institutions that do extensive sequencing. And so then the question is what is the physician's obligation to report the data to the family? And you, as I said, have to educate not only the physician, but you also have to make sure that he now has added clinic time for the appointments that he has to talk to these patients, which add to the cost and may not be reimbursable, which can also be challenging. But I think equally, if not more importantly, I think the education to the patients on these incidental findings is going to be extremely important. Our previous speaker talked about the genetic counselor and how more and more they're becoming engaged and have more and more things to do. Well, this is really going to increase the number of FTEs for genetic counselors around the world as we begin to do this. And I don't know, and I've been looking all over, but and I did a lot of Medline searches in the last few weeks, but I didn't really see any data that was yet available to demonstrate that the benefits of these efforts, at least currently with the cost prohibitive factor, would justify additional cost as well as labor. So the question, how will we train the clinicians to talk to patients about incidental findings? If the ACMG is going to enforce these and they are going to be required and legal issues can result as a result of not reporting to the incidental findings to the patient, then we're going to have to start working on a team approach whenever we start doing this. And then the next question is, what are the patient going to expect from the report of the incidental findings? Does the patient expect that they're going to have this mammoth amount of data that they're going to be able to work on and you know, help them with non-cancer related diseases? Most of them are currently in advanced stages of disease, and for themselves, a non-cancer related diagnosis probably is not that meaningful, but it may be meaningful for their families. And, you know, how are they going to handle this diagnosis, especially already plagued with having an end-stage diagnosis of an advanced malignancy? And then finally, if we're going to get all this data, especially as it becomes identified and used earlier and earlier in a disease stage of cancer, the question is, how are we going to assure that the data will be used in the future? Things such as pharmacogenomics and, you know, how we're going to use this data for other physicians in that patient's future therapeutic armamentarium. How are they going to get a hold of that data and be able to use it so that they don't give the patient the wrong antihypertensive or the wrong cardiac med because of the pharmacogenomics that were identified years before on an incidental finding? But the question is, do patients want to know the incidental findings? And this is a study, albeit limited, that one of the colleagues at Yale is currently doing. Erin Hofstadter is one of the junior faculty on the breast service that's interested in genomics. And she recently completed an extensive questionnaire, several hundred question questionnaire that she gave to each of the patients. And there were about 199 patients. And they didn't, the vast majority of them were adjuvant breast patients. This was exclusive to the breast service. And as you can see, about a little over 60% of them had early stage disease, vast minority having advanced stage disease. For the most part, this was the New Haven community, So about half of them were college educated, and a little over half, about half of them were not college educated, 50-50 mix. And because at the time that she began this survey, many of the patients saw genetic counselors. About 50% of the patients had seen a genetic counselor and had knowledge of what DNA meant to a limited degree. So the first thing she did after she got the demographics is ask the patients, would I want profiling if it were offered to me? And as you can see here, most of the patients either agreed or strongly agreed. Then she went through a series of additional questions talking about if it was going to cost you money, if you were going to find incidental findings, if you were going to find findings that were relevant to your tumor, but we had no treatment to treat your tumor, would you still be interested? And what I thought was interesting is that most of them still agreed. But there was also a disparity in that there was an odds ratio of about 4.1 to 1, with Caucasians more likely to want profiling than non-Caucasians, and the vast majority of non-Caucasians were African American. However, the denominator was relatively small, and I think it needs to expand. And then those who had heard of profiling and seen a genetic counselor in the past were more likely to want to undergo genetic profiling. There was also an Australian pancreatic cancer initiative that was recently reported on 375 patients. And in those patients, 285 patients of the 285 patients that were reported on, the denominator will be 375 one day. There were 25 that had results returned. But of those 285 patients, there were only 4 that were medically actionable incidental findings, 9 that were clinically significant, and 8 were returned because the physician wanted them. And the conclusion was that there was no adverse events from the data reporting, that patients' families, because many of these patients had died because of the diagnosis, were very happy to receive the data, and the results that were returned were feasible and ethically defensible. But they needed a close relationship with the researchers, clinicians, and the geneticists on the team. And I think one of the most interesting studies is the Harvard Personal Genome Project that Bruce might know about. And this is a participatory public research project, which was, it's built on an alternative research approach, which is an open consent approach. So the patients realize that they are compromising, quote unquote, privacy. And the patients were all recruited volunteers to go on this study. It's an extremely high participatory research model, highly engaged, online, where the patients can always see their data as possibly their DNA data is either being used for research purposes, or cell lines that were created from their tumor is being used for research purposes. And this website, albeit extremely expensive, does give the patient real-time updates of their data and allows the patients to update their data as well. And as you can see, beginning with 2,294 accounts, they were down to about 1,143 because the patients have to go through extensive consenting as well as examination, online exams, and have to be able to get 100% on their modules in order to be able to proceed forward. And the vast majority of patients stopped, or the vast majority of volunteers stopped prior to the examination stage, lending about half the patients to eventually go on this trial. But once they were on, the vast minority of patients, as you can see, only 3.8% of the patients withdrew, and most of them remained highly motivated and interactive through the process, getting this updated data. So what about somatic mutations? We know we have a lot of them, and you know, there are a lot of these tumors are extremely hypermutated, and there's extreme heterogeneity. And I think the patients need to know this data. So, you know, and it is the primary focus of tumor sequencing. And I think because of the somatic mutations, we have to look at consenting differently than we would for incidental findings, as well as educate the patients. And these are the challenges and approach differences that we have relative to incidental findings. With consenting in this situation, the primary focus is on safety. The secondary focus is only on incidental findings, who's going to report them, how are they going to receive them. There are data limitations that we have to let our patients know, evolution of knowledge base. The future use of patient data is something that is challenging in a consent form if we're going to create cell lines and PDX models or use their DNA and RNA in the future. And also, you know, other challenges, large panels with possible germline variants. You can't possibly give the informed consent to a patient to extensively interrogate, for instance, a 300 or a 409 gene panel and cover each gene and what it might find. We have to let them know that these are extremely heterogeneous tumors, and up front that they may be challenging to find the actionable mutations, especially in the hyper-actionable mutations, and what the mutational relevance is. And also let them know that even though they're going through these biopsies possibly, that there's only about 10% of the time currently that we will have drug therapies for their actionable genes. We have to inform them that there may be changes over time, that the time point at which we harvest, the location that we remove the biopsy from, that there are platform differences and therapeutic interventions that may be different, as well as the sequencing platforms. So there's a lot that we have to let these patients know, as well as that the data interpretation may vary and that this process is definitely an evolution. There's currently not a lot of data available on how we educate patients, how we communicate this data, and there are very few communication tools that have currently been developed, as well as educational tools. How are we going to review the reports with them? Do we give them complete versus limited data sets? Nobody really gets their entire data set, can't even get it if we're clinicians. And that many genes, we may not even know what they mean, and they may not be relevant ever, or we may find their relevance somewhere down the line and we didn't act on them. So I think, in conclusion, I just wanted to show you an example of where the challenges remain. This was a patient that had come to me a few months ago, and basically one of the problems with many of this data reporting is that there are these clinical trials that these physicians point them to. This patient came to me because this patient wanted monotherapy LEE-011. But if you look at this profile, this patient is never going to respond to a CDK inhibitor. But what this patient needed was a combination therapeutic intervention, which thankfully we had in phase 1 clinical trials. But when you finally give the patients the results, many of them stick to them as if these results are the Bible for their survival. So we really, really have to watch how we end up reporting this data to the patients and what we promise them as a result of getting this data. So in conclusion, I think patient participation in genomic profiling and results is taking on, as you can see, a new dimension with the advent of personalized medicine. I think the educational component regarding patient participation, delivery of results to patients, understanding of the current limitations and realizations of its infancy and accelerated pace is only now beginning to really be addressed. But I think one of the problems is that we really need to study patient education and delivery of data. And as I was talking to Mia, as I was putting this talk together, funding will be needed to help develop and understand the patient's needs and tools beyond therapeutic intervention. Thank you.